you all today. Um, I am going to try to monitor the chat as we go, but if there's something I don't see, please let me know. Um, I don't have any disclosures, and my goal today is to focus some on how we screen and do brief interventions or referral to treatment for pregnant women. And then how we educate patients on treatment options for opioid use disorder and pregnancy in particular. And I have to acknowledge that, of course, opioid use disorder is not the only substance use disorder, and definitely not the only substance that is used in pregnancy. But it is one of the conditions that we have the most treatments for. And and so I am going to highlight it, and it is the one of the substances that is most common here in Tennessee and has a significant impact on our maternal mortality rates in Tennessee. And then I'm going to talk about increasing access to naloxone and medications for opioid use disorder for pregnant and postpartum women. And I'll give you a little bit of information about some of the quality improvement data through our program at Firefly and a little bit about what we do. So, this topic is something that I've been interested in a really long time, but when I think it was maybe in the late 20 teens, early 2020s, we started to get really more robust data from our maternal mortality review committee in Tennessee in particular, but then over the United States in general. And what we saw was that US maternal mortality rates were rising, and overdose was one of the major causes of maternal mortality. And I think that surprised a lot of people. We think of maternal mortality, particularly pregnancy associated mortality, as being or pregnancy related mortality as being things like hemorrhage and preeclampsia. And of course, those are significant problems. But I think that it was a surprise to some that overdose played such a huge role in maternal mortality. And that is definitely true for our state. Um, in the maternal mortality report from 2023, the Tennessee Department of Health really um, put attention on substance use disorder as one of the three leading causes of pregnancy-related deaths at that time. And of course, you can see that the COVID-19 being on here, that was a little glimpse from the past. Luckily, that doesn't seem to be um, play the same role in maternal mortality now. Um, But in this is from the 2024 maternal mortality report, and most of the women in Tennessee who died from an acute overdose that happened within a year of pregnancy. So in that 1 year postpartum, and most died in the 43 days to 1 year postpartum. So um, the that year is a really high risk time for postpartum people, and 80% of these deaths were considered to be preventable. And over half, almost 60%, had mental health conditions that also other mental health conditions besides substance use disorder that contributed, which really speaks to how important it is that we um, during pregnancy and after postpartum, get people plugged into care that continues through that postpartum period and beyond. And the average age of women who died from an overdose was 29. And every time I say that, I'm always just struck by the tragedy of that this is a age when these women are really at the prime of their lives, building families, ideally building careers and being leaders in communities, and are linchpins for parents that are aging. And what a huge loss for families and communities to lose people at such a young age. Um, for many of us in Tennessee, back in the 2010s, early 2010s, really, is when we really started to see an increase in neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. And in many ways, it was like the canary in the coal mine. It really helped us, and really our pediatricians and our family medicine doctors were really on the forefront of seeing babies affected by opioid exposure. And and we continue in Tennessee to have a higher rate than across the nation, as you can see from this. But our NAS Now's case rates have decreased really since the late 2010s, 2019, 2020. And part of that, my pediatric friends tell me, has to do with a change in definition of NAS nows, and it also may be because there really has been a movement to move to treatment of NAS nows and monitoring for NAS nows with Eat, Sleep, and Console versus Finnegan scoring. And so I know that we in our institution have seen a significant decrease in NAS nows rates with a change in how we're scoring. And it's really led to a lot fewer babies having to get treated for NAS nows.
We have a question.
Yes. Oh,
Wanted to
thank you.
know if there were any recorded deaths while pregnant.
Yes, yes, but they're very few comparatively from substance use disorder. But yes, they definitely happen, but the majority are postpartum. And thank you for monitoring the chat. I thought I'd be able to see it, but I can't
Yeah.
with my slides. Um, those are grim statistics, and but I think that what is exciting about this topic and working in this space is there's really a great opportunity to make a huge difference both in the lives of mothers and babies and families. And um, when I first started doing this work and in the years since, what I've started to really understand, and maybe all of you understand already, but it took me a while to really comprehend it, was that a significant portion of our patients affected with substance use or having substance use did not feel comfortable in medical settings. They did not feel comfortable um, getting care. And part of that was from bad experiences, part of that is from internal shame and stigma. And so I've really started to think about how do we make our spaces safe for patients so that they come get care with us initially and then keep showing up. Um, and because you can you can put as many resources as you want into any setting, but if it's a setting that patients don't feel comfortable, then there's a significant number that aren't going to benefit from that. And so the four key things that I think goes into making safe spaces for our patients is using a trauma-informed approach to our care. And of course, there are whole day-long trainings on trauma-informed care. And I won't go into that, but acknowledging and really keeping it at the forefront of our minds that trauma is really common in our society. And particularly with patients affected by substance use disorder, they're at significantly higher risk for having had adverse childhood exposures and then um, abuse and traumatic events as adults. Creating a therapeutic alliance between providers and the patient, using motivational interviewing. Um, I highly recommend doing a motivational interviewing training if you have not already done that. I know they are incorporating that in many medical schools now. It certainly wasn't a part of my medical school education. And I use those skills daily to help um, move people along in their stages of change. And then having a harm reduction philosophy, which for me and our program at Firefly is really about understanding, trying to meet a patient where they are and acknowledging that my goals for the patient may not always align, and people may not be ready to make the big life changes necessary to that we would like them to make as providers. And so for us, sometimes that means um, making sure that a person feels safe getting their prenatal care, even if they're really struggling with abstaining from substances during pregnancy. And so that's really common too. And then acknowledging the risks and how to reduce risks. Um, so I feel like you all in your space are really good at developing therapeutic alliances. Um, but I think that in medicine in general, um, I've really seen an evolution and understanding how that's important and how we do that with patients to really make them feel like we're all on the same playing field and it's less of a hierarchical top-down um, relationship. Um, some of the parts of motivational interviewing that I find particularly helpful is really focusing on open-ended questions. And even Monday, I was doing a consult and I caught myself. I was almost going to say a closed-ended question that was a yes or no answer, and I was like, no, I'm going to rephrase that. And it's simple, but it really makes a difference in terms of helping a patient feel heard and um, helping them express their concerns. I use a lot of affirmations. So affirming the effort that it took to get to their visit, affirming how it might be difficult to talk about a particular subject, giving patients the option to not talk about something if they're not comfortable talking about it, using reflective listening to help make sure that I understand what a patient is trying to say. And then I find summaries also super helpful at the end to summarize a patient's goals and next steps that we've agreed on. So for harm reduction, listening, and I think we all know about the studies that physicians that we tend to not listen as much as we should and spend don't spend enough time letting the patient talk, but really listening, but then also soliciting a patient's goals specifically and acknowledging that their goals may be different from their healthcare providers. But at the same time, we really need to educate on maternal and fetal risk of continued use and implications of that. So I'm not trying to say it's like anything goes and everything's fine, but we're um, also clearly making sure that all the information is understood and that we're discussing treatment options. And sometimes in particular spaces, it's easier to uh, guide a patient to one decision. For example, in my practice space, we prescribe buprenorphine. We're not a federally licensed methadone clinic, though, so we can't prescribe methadone. But and I find sometimes our fellows and others um, uh, maybe uh, shortchange the methadone option because it's not something that we have here in house. And so I think that's really important to be really thoughtful about making sure we talk about all the treatment options. And then offering resources for safer use, naloxone for everybody, but then also letting people know about fentanyl test strips and syringe exchange programs if those are something that are in your area. If that would be helpful to them or to their family members or friends or people in their communities. So I would love to hear in the chat what you all are doing to screen for substance use and pregnancy currently, if you see pregnant women. Um, but I think it's important to think about why we do it. Like, why do we screen? And With screening tests of any kind, I think it's really important that we have um, a action plan if someone screens positive, because and I think sometimes that with mental health screenings and substance use screenings, I think that's sometimes why they get skipped is if people don't feel like there are resources in their community to offer or a clear path forward. ACOG, which is the OBGYN governing body, recommends early universal screening, so an SBIRT, screening, brief intervention, or referral to treatment. And then they recommend that it's universal and part of comprehensive obstetric care and should be done at the first prenatal visit and not based on risk factors, which is what I think I used to see quite a bit. And it's essential that the screening be universal and it should be done with a validated screening tool. And so that's a questionnaire. And those types of questionnaires, there's one called the 4Ps, there's one called the 5Ps, which is in public domain. I think the 4Ps you have to pay for. There's the NIDA quick screen. There's the craft for younger women. And it doesn't necessarily matter what you do, it's just as long as you screen with a validated tool. Of course, I have to acknowledge that there are barriers to screening. Our clinics are busy. There's a lot to talk about in a first prenatal visit. If someone screens positive, then what do you do? And how stressful can that be if that throws a wrench in your entire day? Um, but ideally, what an expert does is simplifies this and hopefully keeps the intervention brief. And then in your community, you have referrals in your organization or practice that you refer to. Um, there are two screens that are specific to drug use and pregnancy are the NIDA Quick Screen and the integrated 5Ps screening tool. And both of these have been validated. And um, the it doesn't matter what you do. I would say just pick one. And a lot of people pick what's already built into their EHR. The 5Ps, it's what's built into our EHR. For a lot of people, it's the NIDA Quick Screen. But I think as long as you're using a tool, that's what matters. Um,
Dr. Young, we have another question. Does anyone do urine drug screening as part of the intake?
I'm going to talk about that. Thank you. That's a good segue. Um, so the 5P screening tool, what I like about it is that it starts externally to the patient and works its way in. So it talks about, do your parents have any problems with alcohol or drug use? Did any of your parents, do any of your friends, does your partner? Before you were pregnant, did you have problems with alcohol or drug use? And in the past month, did you drink alcohol or use other drugs? And there's some places that also add tobacco into this bottom line to do a tobacco screening really quickly within there too, or nicotine products. And then a yes to any of these is a positive screen. And then this is the NIDA quick screen. See, it's much more cut and dry about in the past year, which of these substances have you used and how often. Um, the And so I think I have yes, I did a process map. So you do the screening, you get your positive screen, you have a brief intervention, so you would get a little more history, provide some education around substance use and pregnancy, assess their goals and motivation for change, and then offer naloxone, other harm reduction depending on what they're doing, and then refer them to treatment depending on what you've learned in the history section. Um, and the referral to treatment is going to depend on the substance type. It's going to depend on severity, how often they're using, how severe their use disorder is, if there are underlying co-occurring psychiatric disorders, any medical comorbidities, particularly pregnancy complications that would require an inpatient treatment. And then your options for referrals are outpatient, an intensive outpatient program or a partial hospitalization program, inpatient treatment, or residential slash sober living treatment. This is an example of a process map for an expert at an initial OB visit. This is from the Illinois Perinatal Quality Care, their statewide project on opioid use disorder and pregnancy. And it really walks through the process in an outpatient practice, how you would integrate a validated screening tool into that process. And typically it involves the MA or the nurse, whoever's doing the intake, giving the substance use screening questionnaire, and they could give it verbally, they could give it in a piece of paper, and then if the person screens positive, the provider would be notified, and provider would ask follow-up questions, do a brief intervention, try to assess substance use severity, and then gauge the referral depending on that. This is the 5 Ps flow that we use in our outpatient practices. And so if someone with the 5 Ps, if they screen positive for the first 3 questions, parents, peers, or partner, then that is a indication that the provider would screen for safety and educate on risks of use, because these patients may be at higher risk of starting to use during pregnancy or postpartum. If the person herself um, and reports past use, we want to ask how past is past. Like for some people, when they say past use, it means 2 weeks ago. For someone with past use, they say it means 5 years ago, and that's a whole different um, situation. So we want to review the substance use, and if it is remote and they've been successful in their recovery, just reviewing their support systems and making sure that they feel supported with their recovery. And then for present use, this is where in our practice we would recommend doing a urine drug test at that uh, juncture, but with patient consent. We're not going to order the test without the patient consenting to it. Um, and then, of course, with our routine prenatal labs, we're already getting HIV, Hep C, Hep B, syphilis screening, but we need to make sure that's done if it hasn't been done. And then offering naloxone. And we offer naloxone regardless of the substance they're using, just because there's so much fentanyl in every non-prescribed substance now. It's just everywhere that the risk of overdose from fentanyl is high. And then we refer at that point to treatment and our social workers, but this could be if you're in a setting where you don't have a social worker. If it's a 10 care patient, they have a high risk OB case manager. So this would be a really good referral to make to a high risk OB case manager. And then if they are in treatment, so if they go to a methadone clinic or they're on buprenorphine with an outside provider, this is a really good opportunity to get releases of information for that treatment provider to confirm how stable they are in their recovery. And that's really helpful at delivery for the pediatric team to be able to understand um, how um, how stable the mother has been prior to delivery. So routine urine drug testing. This I think is super interesting because it is, I would say, a test that is used very commonly. It's used very commonly in obstetric care panels, and there are hospitals and practices in Tennessee and throughout the country that uh, require urine drug testing at admission for labor and delivery. Um, but I think that this is against ACOG recommendations, and it's not a screening tool, and it wasn't designed to be a screening tool. And part of the reason is because does not, because of the risk of false positives and false negatives, and the limited time scope that you are potentially looking at with the urine drug test. And it really should only be performed with patient consent and in compliance with state laws. And so there have been hospitals who have been sued. There was a case in South Carolina a few years ago where a patient was tested against their consent and ended up there being a lawsuit about it. Um, it's really important, and I say this as someone that does lots of urine drug testing in my practice. Like I am prescribing buprenorphine, probably 80%, 90% of the patients that I'm seeing get a urine drug test every visit. But that's different than getting a urine drug test as a screening test. It's really important to know your test, to know what it tests for. What doesn't it test for? Many of the commercially available tests don't test for some of the synthetic fentanyls. Many of them don't test, most of them don't test for xylazine. Many don't test for synthetic cannabinoids. Most don't test for ketamine. Um, Kratom is very commonly used, or 7-OH, and that is not on most drug panels. And so typically, a urine drug panel is going to have 9 to 12 substances on it. And um, so you're getting a snapshot of those particular 9 to 12 substances. And then there are some substances like marijuana for a daily user. They're going to continue to test positive even if they've stopped, sometimes up to 30 days, sometimes a little longer with someone who has a lot of adipose tissue. And then some of the synthetic fentanyls also tend to, one of the metabolites of fentanyl tends to hang around a really long time. And then we have got drugs that are very short acting, like cocaine and methamphetamines, where you're only going to test a 3 to 5 day window. So if your test is appropriate, then that tells you that they haven't used those short acting drugs within that short period of time. It's really important to understand the implications of a positive test and to know, does your test um, do confirmatory testing? So, um, rapid tests have a significant risk of false positives or false negative tests. And any of those positives need to be sent for confirmatory testing because there's so many common over-the-counter medications that can cause a false positive. For example, ranitidine, Benadryl, labetalol, sertraline, some over-the-counter cold medicines. There's several commonly taken medicines in pregnancy that can cause false positives. And there are entire lectures that we could do on urine drug testing and toxicology, but I think it's just really important to think about and something I always like to talk to our residents about. When we go to referrals, so we've had a patient, we've identified them as having a substance use disorder or being at high risk for substance use disorder. If they have TN care, this is a really great opportunity to get them linked into a high risk um, obstetric case manager from any of their MCOs, and because they can really help them navigate the care that is sometimes very complicated in our current system that tends to be very siloed. I also think this Find Help Now is a really good resource. Um, and if you, it's Find Help Now Tennessee, and it if you put in the patient's zip code and the type of treatment they're wanting, outpatient, inpatient, residential, whatever, it puts up a list of nearby resources within a certain mileage that you can dictate. And for the inpatient programs, it tells you who has available beds. So it does save some time in terms of calling around. And then if you don't do addiction medicine in your practice, then making sure that you partner with local addiction medicine folks to have referral pathways and be able to do warm handoffs. I think that's super helpful. And in our program, we have monthly meetings with our care partners that we tend to share a lot of patients with so that we can do case review conferences with them. So here's another question I would love to hear in the chat. If there are anything about your screening process that you think that you would like to improve. I'd love to talk about quality improvement and QI. We do a lot of that work with TIP QC And I would love to hear if there's anything around your screening process, either outpatient or inpatient, that you think would be a good QI project. I am going to switch gears to talk about treatment options for opioid use disorder and pregnancy. And like I said at the beginning, of course, opioid use disorder is not the only use disorder in pregnancy. Um, and probably, I would say alcohol is probably more common than we think it is, and it's very hard to screen for. And so I think that is something that um, we in general could probably do a better job of screening for. Obviously, tobacco or nicotine products is the most common substance that's used in pregnancy. But opioid use disorder is the driving cause of maternal mortality and overdose around particular substances in pregnancy. So I'm sure that you all are familiar with medication-assisted treatment or medications for opioid use disorder, and that includes methadone, buprenorphine, and naltrexone. There's also medication-assisted withdrawal, so using medications to help someone um, be off of any opioid or opioid agonist or antagonist um, substance. And whatever pathway is chosen, having psychosocial treatment and support is super important and really critical to success. So for methadone maintenance has been the gold standard with decades of experience during pregnancy. And there are parts of the country where methadone is the primary treatment for opioid use disorder and pregnancy. And that's not the case in Tennessee, but definitely true for other parts of the country. It is a long-acting opioid agonist and is really methadone clinics are really built around a harm reduction model. And there are some studies from the 90s and early 2000s that showed that methadone maintenance increases adherence to prenatal care and also improves pregnancy outcomes compared to patients who are still continuing to use unprescribed opioids. And then compared to somebody who is actively using unprescribed opioids, it does decrease the severity of neonatal abstinence syndrome and probably the diagnosis. For people who are actively using opioids, the risk of baby having withdrawal is probably about 75 to 80%, a little bit of range in some studies. And then for moms on methadone maintenance, the national average of withdrawal is for babies is about 50%. So half of babies will, half of babies won't. And then depending on where a patient delivers and the protocols around the care for the baby, that may be even lower than that. Um, and then there have been some studies that show decreased foster home placement for moms who are stable on their methadone maintenance. The great thing about methadone is patients do not have to be in withdrawal to start it. And that is different than buprenorphine. And so this makes methadone much more accessible for people who can go to a methadone clinic. Um, that for pregnant women, split dosing is often necessary. And sometimes our methadone clinics may not have a lot of familiarity with um, dosing in pregnancy. And so sometimes it can be helpful for us as prenatal providers to advocate for a pregnant woman to get split dosing, so be able to have take-home dosing to take at night because of the increased metabolism of pregnancy. Sometimes with that once daily dosing, patients may have withdrawal symptoms, even though the dose itself is adequate. Generally, we start with 10 to 30, but in the age of fentanyl, people are getting started at higher doses, 30 to 40 sometimes. And for someone who is methadone naive, generally the max dose of 40 milligrams in 24 hours has traditionally been the teaching, but I think that has also changed in the age of fentanyl. The doses are titrated up based on symptoms and relapsing. But because methadone is so long acting, the dosages can't be increased too frequently because doses can stack. So it can take a while, especially with the logistics of a methadone clinic, to get on the dose that someone needs. If they come inpatient, we continue their outpatient dose while they're inpatient. We It's helpful to confirm the outpatient dosing with the methadone clinic, and often um, methadone clinics, especially their pregnant patients, they'll give them a card that says the dose that they're on. So often patients will have that card that they can show you. And what I think is super interesting about both methadone and buprenorphine is that the NAS NOWS risk is not dose dependent. I often hear patients who are describing having withdrawal on 70 milligrams of methadone or whatever they're on, and they're afraid to increase because of the effects on baby. And we have some pretty good literature that suggests that they can, what's most important is they don't relapse during pregnancy because that significantly increases the risk of baby having withdrawal if they're continuing to actively use. Um, the disadvantages to methadone are that they have to go every day to a methadone clinic for some time, often for weeks and weeks and weeks until they qualify for take-home dosing. So if you don't live near a methadone clinic, that can be, or you don't have transportation, it can be really hard to do that logistically. And then because it's a full opioid, people do experience similar opioid side effects and can also feel sedated, kind of depending on the dose, and that can be unpleasant for some people. Buprenorphine maintenance is what I see more commonly, although in the age of fentanyl, I'm seeing more people opt for methadone than ever before because of the challenges of starting on buprenorphine. Um, The advantages to buprenorphine is it has a less severe NAS NOWS with shorter hospitalization and less morphine requirement in general than methadone. It's an office-based treatment, so there are more options on where a patient can get treated. It's more accessible, including can be prescribed via telehealth. And it has other formulations, including an extended release formulation and that the weekly extended release formulation has been studied in pregnancy. It's called Brixadi, and we were a part of that national study, and that was just published a couple months ago in pediatrics, and really showed some improvements in relapse and uh, during pregnancy compared to the sublingual buprenorphine. And I will send a link to that study because I think it's interesting. Um, the disadvantages are starting buprenorphine. In order to start buprenorphine, because it is a partial opioid agonist and a partial antagonist, it occupies opioid receptors. It really binds to them very strongly, but does not activate them in the same way that a full opioid agonist does. So, um, the body doesn't like that when it's used to having all the opioid receptors revving. It doesn't like that partial activation, and so it can cause withdrawal and can cause precipitated withdrawal. So if someone takes buprenorphine and they have opioids on their receptors, it's going to put them into withdrawal, and we generally like to avoid that during pregnancy. We like to avoid it for all people because it makes them miserable, but during pregnancy, withdrawal can cause uterine contraction, severe nausea and vomiting, very severe untreated withdrawal, and that causes severe contractions, could cause um, early delivery, miscarriage, other complications. Um, Buprenorphine sometimes is not as effective for women who are using very high doses of IV opiates or IV fentanyl. Um, and we used to have a max in Tennessee of only 24 milligrams of buprenorphine being able to be prescribed through TennCare. But that just got changed like a week and a half ago. And now the max in Tennessee is 32 milligrams. And so I think that that's going to open up some options for women and people who are using fentanyl in particular and aren't able to stabilize on that 24 milligrams. In some studies, there are higher relapse rates on buprenorphine. And in general, the NAS NOWS rates are between 20 to 45%. At our institution, for our moms, the our rate monthly of NAS NOWS for patients who are on buprenorphine in our program ranges about 20 to 24%. So as I mentioned before, to start buprenorphine, you have to be in moderate withdrawal for a traditional initiation. And that is measured through the clinical opioid withdrawal scale, and that score for moderate withdrawal is greater than 10 to 12. Fentanyl kind of threw all this out because what we found in the day of fentanyl is that people will have moderate to withdrawal symptoms, but there'll still be enough fentanyl in their system where it precipitates withdrawal. So it can be very tricky. And so, um, what we are tending to do in an outpatient setting for those who are in their first and second trimester is micro or low dose initiation, where we start with very, very small doses of buprenorphine, like 0.5 milligrams, and then slowly titrate up every day while they're still continuing to use whatever they're using for about a week. Um, and what is that can be helpful for patients who will not go inpatient and really have no other options to get treated. What we do in an inpatient setting is do a hydromorphone bridge for 24 hours and then start the buprenorphine initiation. Comfort meds for withdrawal are very important and I think underutilized, probably for all people, but definitely in pregnancy. And what we can use safely during pregnancy are antihistamines, anti-inflammatories like Tylenol to help with the muscle pain, our antiemetics. We can use alpha-2 agonists, clonidine to help with the anxiety and cravings, and then using muscle relaxers like cyclobenzaprine can be helpful in this acute withdrawal period. Um, and then a question, I think this is definitely a change from when I first started practicing and prescribing buprenorphine, but we used to think that you could only use mono product. And I'm going to say the brand name because that's what patients say. Mono product is Subutex, plain buprenorphine. And the teaching was that you had to change pregnant women to the mono product. Um, Really, I think out of concern that if they, and this is how the initial studies were done with the mom's trial or the mother study. It was done using the mono product. And I think the thought was, what if someone misused Suboxone? What if they snorted it? What if they injected it? Would it put them into withdrawal and be dangerous for the pregnancy? So there have been more studies that have been done on the Motto product. So conventionally, for years, we've switched pregnant women who are on the combo product, so buprenorphine slash naloxone in pregnancy, to buprenorphine. We have more data that has come out in the last couple of years that have looked at people who've been on Suboxone throughout pregnancies or on the bup-naloxone combination throughout pregnancy and shown that there hasn't been any harm or in much difference. And then there was even one study that showed that there was less withdrawal for babies for moms who are on the combo product compared to the mono product. I'm not sure it makes sense to me why that is or why that would be chemically or biologically, but that's what that one study showed. There is less diversion with the combo product, less misuse. It is safe in breastfeeding. And so currently in our practice, we're about 50-50 right now, but trying to steer people towards the combo product and then they don't have to switch after delivery. It just makes it easier. So what about medically assisted withdrawal? So that would be people coming in for treatment and then being detoxed or tapered off of opioids, typically using buprenorphine. That's what I think is done most commonly. And they're usually tapered off over a pretty short period of time, about a week, with the goal of abstinence. So there are some benefits, and I think it's important to highlight. If someone is successful and completely um, transitioning off of any opioid product for a significant period of time, then there is less risk of NAS nows. But that has to be done at least a month to 6 weeks before delivery to really notice a difference in that. Like someone detoxing a week before delivery, you're not going to see much difference, most likely. And it theoretically reduces concern around long-term effects of opioid exposure for the infant. However, and it also decreases the risk of child protective services and legal action. And I think that's a reality. And in many communities and families, this may be more supported, this idea of being completely abstinence. The disadvantage is it's a treatment of a chronic disease with a short-term intervention. There's risk of relapse, risk of overdose. There are lack of evidence-based protocols on how to do this safely and effectively. And the studies that we have around this suggest that this is more effective if it's done in a residential program, and not just a 30-day or 21-day program, but a long-term residential program. And we definitely have a shortage of residential programs in our state, and um, very few programs that keep mom and babies or in mom, babies, and older children together. And then there are risks of withdrawal without appropriate medical supervision. I'm just going to flash through naltrexone. It's an opioid receptor blocker. It's a monthly injection or a daily pill. The monthly injection is what has been studied for opioid use. The daily pill is also approved for alcohol use disorder. It does require a 7 to 10 day period of abstinence prior to initiation, so that can make it difficult to start naltrexone. There have been a couple studies that have looked at naltrexone in pregnancy, and there is very little risk of NAS nows for the patient population that is successfully on naltrexone. But there are two studies that I'm aware of that have looked at this. Um, so it's still considered experimental. It can likely be continued safely if someone is already on it. Um, but pain management can be challenging. So if someone is on the injectable naltrexone, they need to stop it at 35 weeks. But of course, for those of you who take care of pregnant women, we know that everyone delivers term, and we never see people delivering before they're supposed to deliver. So I think that is something, an education point to talk about with patients who are on the monthly injection for naltrexone, is that pain control at delivery can be difficult if they deliver earlier than expected, and that really needs an anesthesiologist to be managing their pain, and particularly if they have to have surgery. The side effects of medication for opioid use disorder, and these are side effects for any of them, methadone, buprenorphine, and naltrexone. I think sometimes we don't think of naltrexone as having side effects, but it definitely does. Can be all these side effects, and those are all side effects of pregnancy. And so um, being able to manage these side effects is really important to help someone be successful on their medication for opioid use disorder. Pregnancy management, how does that differ? You can see for the first trimester, it's not really different. We should be doing all of these things, with maybe the exception of not offering naloxone to everyone, referring to addiction medicine, but we should be screening for all these things in pregnancy and doing all these STI testing as well. And then I think it is helpful to have a detailed anatomy ultrasound for patients that are opioid exposed or substance exposed. And then for someone who is continuing to use substances or is on medications for opioid use disorder, we recommend doing a monthly growth ultrasound starting at 24 weeks. But we don't do other antenatal testing unless someone is growth restricted or has other pregnancy concerns. And then third trimester, of course, we're doing third trimester labs and repeating those tests. But if someone is using unprescribed substances, we do weekly antenatal testing in the third trimester, whether that's cocaine or amphetamines or whatever it is. Um, Something particular about this patient population is pain management concerns. That can be something that is really worrying for people with substance use disorder. Educating on breastfeeding. Breastfeeding is safe for moms who are stable on buprenorphine or stable on methadone and can be encouraged. And then helping them understand what are the pediatric protocols that you're delivering hospital. Um, do they do eat, sleep, and console? Do they still do Finnegan? How long are they observing babies? At our institution, it's 5 to 7 days for babies that are opioid exposed. So it can be a little different though, depending on where you practice. For pain management, if they're having a vaginal delivery, we're going to continue their buprenorphine or methadone. They can have regional anesthesia. The only thing that you want to avoid is nalbuphine and butorphanol because both can cause withdrawal symptoms. And this postpartum, make sure we're scheduling the NSAIDs and avoiding opioids unless there's a very complicated vaginal delivery. For a C-section, we can also continue our buprenorphine or methadone. Some people find it helpful for pain control to divide their buprenorphine dose or methadone dose postpartum. So they're taking it Q3, I mean, it's not Q3, Q8 or Q6. Um, Again, regional anesthesia, local anesthetics, the CAP books can be super helpful. Having a multimodal analgesia plan that includes NSAIDs and short-acting opioids as needed if that's part of that patient's recovery plan. Some patients with opioid use disorder want to do everything possible to avoid opioids, and those patients that should be honored. But if a patient needs short-acting opioids, 3 to 5 days is what we do. And then we tend to start with hydromorphone rather than an oxycodone product because of its affinity for the opioid receptors. And there is some anesthesia data about increasing the dose, the 24-hour dose of a buprenorphine that patients are given in order to avoid short-acting opiates. And so that is something that is possible. It just patients need education around what to continue when they go home so they don't end up short or running out. This is a postpartum plan of care, which hopefully your hospitals have. But you can read these later, but it has the educational components that are recommended, naloxone prescribing, making sure we're doing education on PMADs and a contraceptive plan, and linking people to services if they don't already have it. Um, this is a comparison of the Eat, Sleep, and Console model for care of the opioid exposed newborn compared to Finnegan or NAS Now scoring. And you can see that the ESC really focuses on functionality, and the assessment is yes, no, um, based and uh, not based on a numeric score, which can get vague and has inter-rater variability concerns. And then the treatment approach with ESC is non-pharmacologic care first, so rooming in, skin to skin, breastfeeding, where Finnegan really prioritizes early pharmacologic treatment with opioids or other, typically morphine. And the length of stay tends to be shorter with ESC, 5 to 7 compared to 14 to 21. And then what our patients love about ESC is it really encourages family involvement and family-centered care. And what our pediatricians tell us is that by the time a baby needs pharmacologic treatment with ESC, the families recognize it and they just have better buy-in with ESC. The fourth trimester is super important. And so our general plan is we see people in 1 to 2 weeks postpartum, 4 to 6 weeks postpartum, and 8 to 12 weeks postpartum, unless it's someone who is unstable or we're just starting them on buprenorphine, then we're seeing them weekly during this time. And of course, making sure we're getting them plugged into all the other health related needs that they might have, including getting them treated for hepatitis C. This is some information on our program. We serve about 300 patients a year, and most are on TennCare. And most of our patients, they go to the term. So 80% of our deliveries go to term. And why isn't this going? There we go. Um, and 18% of our infants go to the NICU, and most of our patients breastfeed, which I think is really exciting and higher than what's the national average for patients with opioid exposure. And this is our um, general flow, which is, or services offered, which is really about offering wraparound services to help prevent relapse during pregnancy and make sure that they stay linked to care both for moms and for babies after delivery. Um, a little bit of our QI data to share. So our relapse rate during engagement is about 42%, versus 65 to 91%, which is kind of the national relapse rates around opioid use disorder. And I think really speaks to how, like, this is a chronic disease and it's really, relapses are common, but how we engage people to keep them from relapsing and reducing the frequency. Um, and then most of our babies are on medication for opioid use disorder at the time of delivery. I already talked about our breastfeed rates. Our discharge home to bio mom rate is about 91%. And that's compared to 66%, which is what we got from our TIP-QC data from an opioid exposed newborn project. And our average length of stay for babies is 5 days if they do not get diagnosed with NAS, and 13 days if they need treatment for NAS. So I am going to stop sharing, but I do have resources in this lecture, including the buprenorphine treatment guidelines in the state of Tennessee. And I've only left a little bit of time for questions, but I would love to answer any. And thank you very much.
All right. Thank you so much, Dr. Young. That was great. Do we have any questions for our speaker? Yes, Dr. Belak.
Early on, I think it was the algorithm of the process of coming in for intake.
Yeah.
You mentioned there was a term that said, discuss the substance use policy. And
Yes.
so that wording sounds like we don't want you to be on drugs, but I don't think that's the point of that message. So how do you explain that? What is your, how do you explain the substance
Yeah,
use
well,
policy?
I think it's really important that patients understand the policies of the delivering hospital and like what that looks like, and that's going to look different for every location, but almost certainly if someone is continuing to use drugs, this during pregnancy and up into delivery, um, the every hospital policy is going to require a DCS report or a Child Protective Services report in that scenario. And that may seem obvious to us that that is the outcome of that continued use, but it's not always obvious to people. And so I think that it's important to be upfront and honest about like what could potentially happen. I think the other thing is to, um, if you are doing a urine drug test, um, letting a patient know like how that could be potentially used or not used. Like, so for in our setting, having a positive drug test, even in the first trimester, if there's not documented uh, negative tests after that, then our pediatric team is that patient's going to need a social worker for referral inpatient, and will likely um, would be considered for a child protective services report. So that's what I was referring to with that.
All right. Do we have any other questions? I know we're